Good morning, everybody.
Morning.
You guys hear me okay?
Yeah.
All right, good. I like to usually walk around, be interactive, but I think we're recording, so I'll stick to my spot. This is very much a home crowd for me, so I'm very excited to talk about some of the new things that have come up with colon cancer screening. Do we have a presentation? Not that I know. We don't have a presentation.
I did a video of a colonoscopy.
I do in the presentation.
I volunteer Chris to help.
Did you email?
I did.
Patient? Yes.
All right, we're gonna wing it, guys. So, okay, let's see how good I know my stuff then. The last time I gave this talk, something happened to me that has never happened before. So, I think it was maybe last fall, and it was Golden K Kiwanis. Who knows about that club? It's very much, how do I say this? The demographic is skewed northward. You know, it's a very, it's Golden K. So I usually start off this talk with saying, well, everyone raise your hand if you have a colonoscopy before. So you got a spattering of hands here and there, but with that group, every single hand went up. And that had never happened before, so then I didn't talk and I just left, so. But the reason I want to talk about this is that there are some changes that have happened recently. I think the biggest one, first and foremost, is that the age for screening was 50 for the longest time. It's now dropped to 45, which means overnight there might be some of you in this room who are now due or overdue for your colonoscopy screening. So the couple of take-homes, this is very interactive, by the way. Please ask as we go. I'm not going to drone at you, especially if I don't have a talk. So the biggest thing is age 45. The other thing is know your family history. You know, most of us, our parents, have had a colonoscopy by now. It's been out since 1992. So, you know, we know our parents have had it. So it's worth getting into it's worth, isn't it, diving in? It's worth learning about your family history. You know, if your parents had a colonoscopy, hey, mom, dad, did you have a polyp? Did you have something? If your parents had colon cancer, then you're at even increased, you know, early on, you know, talking age 40, age 35 even. And that might sound alarmist to some people in this room, but there's actually a paper that came out last week. You know, when I signed up for this about a month ago, but last week a paper came out that from 2004 to 2016, they look at data. People do look at data all the time. The incidence of colon cancer in ages 20 through 29 and 30 through 39 went up 113%.
Wow. Yeah.
And that made me pucker up, no pun intended. That, because it's what we see. I mean, I will often do a colonoscopy for someone with diarrhea, and I'll go in and I'll see a big polyp, 20 millimeters. And I'm thinking, they're 25 years old. They would have never made it to 45. It would have been that horror story that you hear about a 34-year-old with colon cancer. So that happens a lot. And so that data, it goes into a guideline and then they publish it and everything. And so that's why the age dropped from 50 to 45. So I don't mean to alarm you or frighten you in any way, but it's just really important because it's a completely preventable cancer.
I do have a question.
Yes, Tracy.
Since I'm working in to get my rear in the clear with
Yeah.
you, what all is involved in a colonoscopy?
Good question. Good question. I'm glad you asked. So the first thing is, you know, you got to get scheduled. Okay. The next thing is the bowel prep. Everyone's gone through the bowel prep. You'll lose a couple of pounds during the bowel prep. So it used to be this really big jug. Who had the jug?
Oh,
Yeah. So it used to be the jug of something called Go Lightly, which is a cruel twist on words. It's anything but Go Lightly. So now they have smaller volume preparations. They're 2 small bottles. You know, when I did mine 3 years ago, it was basically like 2 cough syrup bottles. And you take one in the morning, at night before, you drink a lot of water. You take one in the morning beforehand and it cleans you out. But last year, we actually now finally went back to pills. So now you can do pills.
Good, so I waited long enough.
Yeah, it's called Sutab. Suprep, Sutab. So that's a big thing because a lot of people, I mean, and people who have had it, I mean, the issue is not the colonoscopy. The issue is the bowel prep the day before. So there are tablets now, so capsules. So that for a lot of people, that's a game changer.
Well, I'm very inquisitive. So say somebody, a patient comes in and claims to have done that, but they really didn't. What happens on your end or their end when you start? How does it, what really?
Are you
what
asking for a
really
friend?
stops it?
Julie, are you asking for a friend?
So are you referring to the possibility of an incomplete preparation?
That would be, yes.
Yeah. So once you get to our endo center, you'll go through a questionnaire. And there's actually a really cool color graph that goes from clear to brown. And you got a color code and point to the last bowel movement you've had. A lot of times you'll have one right there in the center. If you've got floaties, you can't proceed. So you got to be clear. Otherwise, if I go in, I'll see a brownout. Then I can't see. So
you're only hurting yourself.
so you can't
You can't
fudge your way through. Oh, no.
Leave it on
There's no way. We'll see right through you. So, yeah. Oh, we do it.
He's
Magic. Well, we got to take
So how
care
do
of it.
I click? Or do you do it?
I'm going to have to do it.
Okay, all right. So I actually
What
like
was
the
the
press
cartoon
conference version of it better.
Why did we
So-
miss the cartoon?
Okay.
Yeah, the VA going on. Yeah. What's that one for, great grandpa? I survived the VA colonoscopy. So I like that one. All right, let's go next here. Let's see. Yeah, the two take homes from this slide. I just asked Laura before I came up, how many members do we have? We have 117. And if you look at the nationwide average of polyp incidence, about 25%. So who's the math person here? Who's 25% of 117? 25% of 117. Why can't I do math? 30 something. 30?
25 to 30%, yeah.
So anyway, so that means we've got, about 30 to 40 people in this club who today have a polyp. So think about that. And polyps are the things that become cancer. So people ask, like, where does it start? How does it happen? And the best way I describe it is, it's like a mole on your arm or on your back. Some of them are benign. You were born with them, nothing, they're birthmarks, right? They don't progress. But we've all kind of learned that there's certain moles, if they grow, if they expand, they change color, if they elevate, if they're new, you're like, yeah, that's not normal. So it's the same thing with polyps. I'd say about 75% of polyps are benign or hyperplastic. Those are the ones that don't bother anybody. The other ones that become cancer are called adenomas. Those are the ones that actually progress to colon cancer. So the nationwide adenoma incidence rate is 25%, which is that number 117, pick 1 in 4. And then with colon cancer, it's about 1 in 25. So that means today, and this is that's why I want to talk about this. Out of 117 people, we have 5 people with colon cancer right now. So that's why this gets really personal to me. Like in my circles, whether it be the Chamber of Commerce Board, whether it's this Rotary, whether it's mosque, wherever my circles are, I'm like, at least the people that I talk to, that I interact with, let's make sure you get screened because it just is getting more and more common. So next, those are the parts that go and move on. I should have warned you, sorry. Those are what polyps look like. Next one.
Okay.
Risk factors. People ask me, they're like, hey, what leads to colon cancer? It's very similar to heart disease. Just kind of, people say, does diet matter? And like, we have associative data, we don't have causative data. So it's just heart healthy is kind of the way to go. If you think about risk factors and diet. Next slide.
I didn't know gallbladder was one of those.
Yeah,
That
removed,
just
that can increase.
Okay.
And why is that? Because when you remove your gallbladder, your bile no longer has a place to be stored. So it's constantly flushing into your colon. They can cause irritation. And most cancers start, by some kind of offending agent. Mm-hmm. And so if you irritate the wrong way, it can continue to grow. Symptoms and signs. So these are the ones. If you're like under 40 and like you have constipation, you really should be checked out. Like we kind of ignore it. I can't tell you how many, at least 20 people like in the last 10 years where I'll see a 28 or 29-year-old male or female, and they've had blood and stool and abdominal pain for like 10 years. And their working diagnosis from their primary has been irritable bowel syndrome. Who's heard of that? Mm-hmm. Irritable bowel syndrome, and it's hemorrhoids. He's a weightlifter. But you go in, they might not have cancer, but they have raging Crohn's disease. And you're thinking, oh my God, this person's been suffering for like 10 years. So if you're under 40 and you're not regular or you got issues, just get checked out. I mean, it may be nothing. It might be irritable bowel syndrome, but it could be something very treatable. So, next one.
Raging Crohn's disease is extremely painful.
It's what?
Extremely painful.
Yeah.
I think you would want to explore all avenues.
But again, how many people under the age of 40 have a primary care dog? So, we're invincible until we're not. And so that age is dropping. Where'd we go?
I'm clicking the wrong buttons, sorry.
Okay.
How far back did I go? Okay.
Thank you.
Let's get to Tourette's.
All right, we changed that. Yeah, we talked about that. Age 45 is the new age. We can go to the next one. Here's the other key thing I wanted to say. Obviously no one wants a colonoscopy. It's kind of weird if you do. So there are different ways to be screened. And so who here's heard of a test called Cologuard? Like on TV, radio, magazines. So Cologuard is a test that is stool-based, along with another one called IFOB or FIT. So FIT is a stool test that looks for microscopic blood in your stool. Your stool looks brown, it looks fine, but when we test it, there's microscopic blood. So that's a problem that needs to be followed up by a colonoscopy. A Cologuard looks for blood along with two other things. They're microscopic genetic mutations, but you're really looking for abnormal DNA in your stool. It's kind of weird when you poop, but you're looking for those abnormal mutation markers in your stool. If your Cologuard is positive, you need to have a colonoscopy. But if these are negative, that actually is enough to be screened. So I'm not standing here demanding everyone get a colonoscopy. I'm saying if you have a family history or if you're 45, do something. It's not as important which one you do as long as you do one. If you do a stool sample that's negative, you're fine. They're not perfect, but they're pretty good. So that would be one of my really big pearls I want you to take away from this. Like I said, there's no one really volunteers for a colonoscopy, but if we can talk you at least into a stool sample just to make sure, it gives you a lot of coverage. Next. Wow, this prep is so delicious. I think I'll drink another. Said no one ever. So, yeah. We kind of talked about this, and then people always ask me, they're like, oh, when I used to do my first colonoscopy, they told me to come back in 2 years. Now I'm telling them to come back in 5 years or 3 years. When do you come back? Well, it depends. The guidelines always evolve. Every 3 years they change. Number two, it depends on how many polyps we found. It depends on the type of polyp we found. So there's a number of factors that kind of establish your own individual risk profile, and that determines when your next colonoscopy will be. If it's normal, no family history, you get a 10-year clean bill. If you find one, it's 5 to 7 years. If you have family history, you're on the 5-year plan regardless of whether you found polyps. Yes, Axel?
What's the highest number of polyps? What's the highest number of polyps you found?
I found my record, 32.
Wow.
Yeah, 32. And so that's somebody you don't surveil, you send to surgery. You remove that organ because it's just too high risk.
Did he survive?
Yeah, they were fine. You just do an empiric colectomy, and then that way they don't get colon cancer. It's a bit dramatic, but again, if you have 32, that's the right way to go. Next slide. Oh. We have a lot of humor in GI about this. So, can you click on this? Are you able to play that? I know sometimes it's like, yeah, this is a real one. So that's a polyp. This is iMovie, by the way. So that's the polyp. That's our tool that we use. It's called a snare. We put that through the scope and we close it, and now it's gone. So then we send that to the lab for testing. But basically, it's precancerous tissue. It doesn't belong in your body. Get it out. Stool test, we talked about.
Omar,
Yes.
is there heat during it, or is it just just cut it off?
Good question. It depends on size and location. So it's gotten a lot better where we used to use heat for everything, but we're actually transitioning more to cold or without heat. The snare filaments are a bit sharper. They're a little bit different. They're evolving. They're a lot better even when I started out. So it depends on the size of the polyp, and polyps can be different. If it's on a stalk, like a mushroom, you can tell there's a big vessel or artery there. You'll need heat, and so, but for the majority we use cold, because cold has the advantage where it'll bleed right then and there, but it won't bleed 5 days later. If I use heat, there's a little scab there, and I start you back on your blood thinner, you might bleed from that site in 7 to 10 days. So we try to use cold.
As long as it takes to heal up after polyp removal.
If it's cold, it's just like removing a mole, maybe 24 hours. If it's heat, I mean, you won't feel anything. But for heat, we say avoid blood thinners for 2 weeks because that's how long it takes to kind of heal. Was there another question somewhere?
Just how does that open wound heal when it's in an environment with fecal pad?
It's very small. I mean, that's tiny. That was only 4 millimeters. So yeah, there's no problem really with healing unless you're on chronic steroids, or if you're immunosuppressed in some other way. Otherwise, it's really a non-issue.
So if you get a negative test and it's 10 years, how can it go back in 10 years, or what's the time frame?
So let's look at it this way. Let's suppose today you had your colonoscopy. So tomorrow's day 0. So a polyp could start tomorrow. So what you're really asking me is the natural history of a polyp. And so the natural history of polyp is anywhere from, depending on the data you look at, 7 to 12 years. And that's what informs our interval recommendations. So again, you could have a completely normal exam today, but nothing precluding you starting making a polyp tomorrow. But we think, you should be able to catch it in time before it becomes cancer.
What are the symptoms if you have a negative and you're gone for 10 years? Like, you're still...
Yeah, I mean, there was a study in Poland. They looked at people, they've been following them for about 24 years, and we think that if you had a good quality exam with a good bowel prep and a good look and everything, none of those people had recurrent polyps 17 years later. So that kind of helped us with that 10-year recommendation. So.
Omar, if you were speaking to a group of students, medicine students, what would be, from your experience, coming across when you came into the practice of medicine and knowing what you know today in the field of the business side of medicine, what would be your advice, or what would be what's your takeaway for the new med students coming in?
In terms of medicine or colon cancer screening?
In terms of medicine with business, the whole business of medicine. How it's changed, because it's changed dramatically.
It is. I won't go too much into it. It's a bit out of the scope of this talk, no pun intended. But I mean, the healthcare dollar is a pie. You have the physician part, you have the insurance part, you have the pharmaceutical part, you have the patient part. And that pie every year adjusts. And so I'm certainly not going to talk to you about physician portion of that. It's obviously different than it was 30 or 40 years ago. But that's how I have to look at things. And just like my 10-second tangent, looking at, everybody in this community, when it's a normal, we're all paying for each other's healthcare. It's a communal resource because none of us are paying cash out of pocket for our care. We're all contributing in some way, shape, or form to a pot. And so the question kind of arises is, who, we contribute to that. How does that get allocated across people who need more healthcare above the age of, say, 60 or so versus people who are younger? And so we kind of have to get to societally where our responsibilities to each other in terms of healthcare. And that's been very, very, very jarring the last 24 months with COVID. I'm just going to say there's a trade-off between individual freedom and individual responsibility. And so we see that literally every day in the hospital, and it's hard to see. It's hard to see. So I didn't answer your question completely.
Thank you.
So yeah.
So with the adjustment of age, have insurance companies made that adjustment as well too, and that they are paying for them, advocating for them? I would guess as an insurer, they want to see this test, this procedure happen because of the savings in the long term.
You nailed it, Chris. I think maybe until a year ago, there was a little bit of pushback. So the societies, the GI societies recommended age 45 starting 2020. The American Cancer Society actually recommended 2018. But the main sort of organization called the USPSTF, the Prevention Task Force, they last October, I think, went 45. So for any insurance company to deny you, they'd be the ones for a change fighting the uphill battle to justify why they wouldn't cover it. So I have not seen any kind of denials or anything. But what I will say is if you're between 45 and 49, do a stool test. You have to have a colonoscopy. at some point, because of the imbalance between the population and gastroenterologists, I don't think we'll be screening people who are normal risk. I think we'll be screening people who have positive stool samples. And that'll be the best juice for our squeeze, probably 5 to 10 years from now. Next. Yeah, the best test is the one that gets done. Next. Aha, yeah, one more time. Yes, this is the money slide. So,
Oh my God, I'm going in. Please, those comments.
but honestly, this is old. This is, I should probably update these to like 90s. This is 80s.
Put the Commodore 64 up
Yeah,
there
you
and
need a
stuff
new
like
one.
that.
I think it's Sega Genesis or
Sega Genesis, there you
N64. Really?
Actually, all you need to do is keep this and then add the 90s one after.
Right.
Because then
That's true.
You got them both.
those people will say, we're out of, and then you'll pull up the next screen.
Yeah. That's
What
true.
happens if you did both of those things?
That's beyond the scope of this conversation. Sergeant. So, is there anything else? I think I might.
That's it.
Yeah, I think that's it.
Yeah,
So,
that's it.
I'm glad we had that. Yes.
Asking for a friend, if you don't have a general doc, do you need a referral for a colonoscopy?
No. You just call our office.
Okay, you started the prep, so then you don't have to worry about this when I go in. What then happens after that? Exactly when you go in that day then?
Okay, so we'll go over the process. So clear liquids the day before. So let's say your colonoscopy is tomorrow, it's Wednesday. So clear liquids today. Anything that you can see through, apple juice, chicken broth,
But
water,
isn't coffee a clear liquid?
Gatorade. Not quite, depends on the end. So clear liquids, and the bowel prep would be tonight. Drink a lot of water with it. The second part of it would be tomorrow morning, probably about 5 a.m. You come to our office, change into one of those gowns that you put on, but you actually feel more naked. It's they'll put an IV into your arm. You'll get anesthesia. You'll be out for about 10 to 12 minutes. It doesn't take very long, you know. So, and then I say hi. We do the scope test. Take a bunch of pictures for you for your Instagram and stuff like that.
Nice.
Give you a copy when you wake up.
Can I do a selfie while I'm in there?
Yeah.
That's your call. HIPAA doesn't apply if it's you.
You don't mind drooling.
Then hopefully you wake up, you burp, you fart, make sure you do all those things before you leave, and then you're done. And so it's a pain in the, you know what. But for 24 hours of a little bit of discomfort to know that you're not going to get an internal cancer, it's a pretty good trade-off.
How long does the procedure take then?
The procedure, it depends. So first we go in. It takes about 3 or 4 minutes to go in, depending on anatomy. And if you've had previous surgeries, C-sections, things like that, it can take a little bit longer. So it takes about 2 or 3 minutes to get into the end, the cecum, and then pulling back, it's about 5 or 6 minutes. If I see a polyp or if I see something to biopsy, it'll take a little bit longer. But on average, the whole thing takes about 10 to 12 minutes.
So there's also, like, for those, like, I don't know, 5 to 7 days before things you're not supposed to eat.
Yeah, we do recommend kind of a low residue diet. You know, try to lay off the pork chop, pizza crust, fried chicken. Try to go to softer things. That way, when we do give you the tidal wave, you know, we can get things out simpler.
So it talks about cabbage and like other.
Yeah,
vegetables
roughage.
too.
Yeah, so salads, you know, because those things can linger sometimes. And I can't tell you all the different things I found. So,
We don't.
good.
I just want to tell, I'm not embarrassed to say this, but I am a patient of his, and it was so super easy. Like, I was so scared, like, does it hurt? Are you gonna be violated, feel like you're violated the next day? Or am I embarrassed to see you because we know each other really well now?
I'll be honest, a lot of times I don't recall.
So, your staff was so, like, comforting, it was not embarrassing, it was just, it was very quick, 10 minutes, and, you know, you did the rear and the clear, and that was it. It was so funny, so you made, it was very easy experience.
Good, thanks.
So we're amongst friends, right?
We're amongst friends.
What is the weirdest thing you've found?
Wyatt's in the house. It's okay. It's all right.
Organic or non-organic? So just
You ever find like a diamond earring?
Trophy?
people are people. People are gonna people. It's especially when substances are involved, people do some interesting things. So, yeah, it's never a dull moment, yeah.
I'll save you, how about that, okay?
Thanks.
So you mentioned the pills, and I remember a long time ago, there were pills, they went away. You kind of went quickly through that. Because I think that the PrEP has always been the biggest issue.
Yeah.
So the pills, how they work, how many are they, what's the difference between the liquid and the solid?
Yeah, so basically, it depends a little bit on formulation, but I think it's 24 small ones, so don't get alarmed, they're really small. So 24 on the night before, and then 24 like at 5 a.m. or 4 hours prior to your procedure, whenever that is. And you just take the pills, and then the important thing is to hydrate. A lot of people just take the pills and they just kind of go to bed. It's like, well, you gotta drink your Miralax or your Gatorade, your vitamin water, or whatever you want to drink water. Pro tip, they say with the go lightly, this is important. You get the canister and there's powder and you got a clear liquid in it. Don't use vodka. A guy did that. And he had a really messy dry cleaning bill. Seriously. He actually prepped with vodka. He couldn't make it to the bathroom, there was mess everywhere.
Does not even get.
So anyway, I didn't think so, but I want to clarify.
Water.
I've heard stories of people in recovery. What is the strangest thing that people have said in recovery while they're waiting to be let go?
That's any anesthesia. I mean, people are happy. You get to learn a lot about people. Yeah, so it's all, as Susie will testify, I mean, like, it's very, there's boundaries, whatever happens, when you come in, when you leave, that's just kind of a sacred space.
It only surprised you the first couple times.
So what?
It only surprised you the first.
No, it's still surprising. No, there's people who are really practical jokers in this Rotary who are not here, or unnamed, who actually leave me notes on their cheeks. So when yeah, Sharpies, tattoos. People are people. Yeah,
I won't mention any lower names.
No, I'm not. No, unnamed. Yes.
So obviously surgeons do this procedure as well. I was curious your take on surgeons versus a GI and why.
Ultimately, there's not enough GI to fulfill the demand that's there. So if there's someone else doing it, fine. What I'll say is that as a gastroenterologist, we have to adhere to quality metrics. We have to look at how long it takes us to get from the end to the entirety of the colon. We have to look at how many adenomas we find. We have quality metrics. In training, we have to do 300, surgeons have to do 25. And obviously, once we're graduated, I do 2,000 a year, so I've done 20,000 probably. So it's a lot of backsides. So,
How about like perforation, like for like a rate surgeon? Yeah, I think the person did 2,000 a year versus less.
It is higher in other specialties who perform colonoscopy, and the benefit they have is that if it happens, they can fix it. So they're a little more aggressive sometimes. Chris?
How many are you performing in a given day, and how, so are you working are you in surgery 3 days a week and you're doing 10 in a day, or what's that look like for you?
So my schedule is Monday, Wednesday, Thursdays procedures. I do about 24 a day, and then the other days are clinic days. So.
And has it been harder to get the space to do these procedures in this COVID time, or have you been able to keep the same pace? What does your patient level look like in this?
Well, and that's actually a big issue, because we were delayed about 3 or 4 months 2 years ago. Was it 2 years? Yeah, 2 years ago. So that gap, there's this huge backlog. So that's why we've actually said just go get stool tests for now, for people just to get caught up. So within the OSF system, we have metrics. So we have to look at how many patients have a green checkbox, meaning that they are colon cancer screened. And so we've kind of pushed to the primary care docs. So you can't get in for colonoscopy, at least do a stool test. We can at least get some coverage out there, especially as you get out to El Paso, Pontiac, Clinton, some of the places where the rates are lower. Just get stool samples, at least get screened somewhere. So, there.
So give us a little insight why you picked this profession, your journey into this.
I wish it was something loftier, but my dad's a GI doc, so it kind of runs in the family. My first mouse pad in Peak in 1988 was a drug company shaped of a liver. Like literally, I had Zantac mugs and pens, and so I kind of just grew in it. And so I thought about other specialties during med school, but ultimately I like the cognitive as well as the operational. It does, both things. I think if I was in the clinic 5 days a week, I'd go nuts.
Your dad still practicing?
Yeah, well, no, last February, he retired. Yeah. Other questions? Yes.
We have just a few minutes. Normally we have a vocational and a speaker, but you get that overlap, a speaker committee. Could you just tell us about yourself for a couple minutes, about your background, and let us know? Do a vocational for
You
us.
can't say no.
I'm in mourning at the moment. The 49ers almost won. So I guess what a lot of people don't know about me is that I grew up in Pekin and Peoria. Richwood's 96. So I grew up in Pekin and Peoria, and then my dad and 3 other guys started a hospital in Pakistan in 1993. So I was a sophomore at Richwood's when we moved to Pakistan. So big change. We'd visited before. So it was definitely a big change. But the cool thing is that I could make the basketball team. There was no way I was making the basketball team at Richwood's.
Not a chance.
No. But it was kind of cool being there because I was at the international school, and so the conference there was Islamabad, Lahore, Karachi, New Delhi, Colombo, Dhaka, Kathmandu. And so that's how you had your tournaments for stuff. So we won 2 championships in high school. That was kind of cool. So, and then I never ever thought I'd come back to Central Illinois. Everyone wants to go to the coast or Chicago and stuff, but here we are, 12 years. So,
Did you start in Peoria or here?
I was in Peoria for 2 years with a private group, and then OSF wanted me to join OSF, and then in medicine you have something called non-competes, and so I couldn't go from Methodist to OSF in Peoria. So the plan in 2012 was to come here for 24 months and then go back to Peoria, but I loved it here so much that I stayed here.
What was the private group?
Illinois Gastro Institute. Yeah, so affiliated with
My wife
Methodist.
had Crohn's disease.
Oh, okay, yeah.
Pretty much in Peoria, so.
Yeah. Hi, do you have a question? Yeah.
He was pre-pledging.
Oh, it was pre-cloud. Okay. All right. So you're doing IQ. So then we're done. All right.
I want to wait to the end because everybody remembers the Luton Edge. I'm
Yeah.
still mourning the loss of that. Is
So
that ever gonna come
The
back?
Edge is still alive. They're in storage. We just don't have a lease with the arena right now. But it's
Football
still,
players are in storage, that's-
it's what? The players and the coaches are not. The uniforms and the gear is all in storage, ready to go if we can, at some point, come up with an agreement to play in the arena. But kind of a blessing in disguise with COVID the last 2 years. So, because some minor league teams literally just did not make it because of different reasons. So maybe.
Well,
Maybe.
big shout out to Omar, guys, because he brought that to this town. It's really awesome to see that.
Thank you, guys.
Thank you for being here. It's good.
Yeah.
So,